This bottle of hydrocodone represents the clinical point of origin for millions of cases of dependency. To understand the current crisis, we have to look at opioid use disorder as a medical condition, one frequently rooted in the formal healthcare system. Prolonged drug consumption causes physical alterations to the brain's neural circuits. As seen here, the substance hijacks the pathways responsible for motivation and learning, effectively reorganizing the brain's priorities around continued use. When an individual attempts to abstain, they face an agonizing range of physiological symptoms. Withdrawal brings about severe anxiety, depression, and physical distress that can be nearly impossible to manage without support. This chart shows the statistical outcome of that physical pain. Because the symptoms of withdrawal are so intense, 80 to 90% of individuals relapse. The physiological barrier to abstinence is often too high to overcome through willpower alone. This biological rewiring overrides a person's autonomy. By the time the brain has been altered at a cellular level, the condition is no longer a matter of personal choice. It is a self-sustaining cycle of dependency. Because of the heavy societal stigma and the threat of criminal penalties, many people struggling with addiction are forced to hide their behavior, moving away from safe environments and medical oversight. This isolation creates high-risk conditions. In the shadows, individuals often lack access to sterile supplies, leading to the use of crooked needles or equipment shared with others. Shared items become vectors for a secondary epidemic. The hepatitis C virus spreads through blood-to-blood contact on tools like spoons and water bottles. Testing shows it remains viable for 14 days on a spoon and up to 21 days inside a water bottle. Beyond the liver damage, the virus also invades the central nervous system. This causes cognitive decline, mental slowing, and depression, further complicating the patient's ability to seek help. When addiction, infectious disease, and mental illness converge in this way, they create a syndemic, a web of health issues where each condition makes the others more difficult to treat. The tragedy of this syndemic is that a highly effective cure already exists. Hepatitis C is no longer a terminal diagnosis. It is now a curable condition. A 12-week course of modern protease inhibitors has a success rate of 95%, and the side effects are minimal compared to older interferon-based therapies. However, the barrier to this cure is financial. Due to corporate pricing strategies, the cost of the drug is roughly $1,000 per pill, putting the full treatment out of reach for most. These prices drive restrictive Medicaid policies that deny coverage to the uninsured and the most disenfranchised. Even when a cure is sitting on a shelf, many patients are legally and financially blocked from accessing it. The persistence of the hepatitis C epidemic isn't a failure of science, it's a failure of policy that prioritizes profit over the distribution of life-saving medicine. Historically, the war on drugs has framed addiction as a criminal issue. This model relies on mandatory minimum penalties, police enforcement, and forced rehabilitation to control substance use. Research indicates that these punitive measures do not improve long-term outcomes. Instead, the threat of jail and social exclusion often exacerbates the trauma that fueled the addiction in the first place. An alternative is the harm reduction model. This paradigm shift focuses on minimizing the negative consequences of drug use through non-judgmental, practical strategies rather than punishment. Needle exchange programs are a core part of this model. By providing sterile syringes, these programs eliminate the primary blood-to-blood transmission route for HIV and hepatitis C. The effectiveness of this model was proven in Portugal. After decriminalizing illicit substances in 2001, the country saw immediate and sustained drops in overdose-related deaths and new HIV infections. Harm reduction doesn't enable the addiction. It protects the patient's agency. It keeps them alive and within the healthcare system until they are physically and mentally capable of seeking further treatment. The most effective bridge into the healthcare system is often a human one, the recovery coach. These coaches are often survivors who have lived through opioid use disorder and successfully navigated the treatment for hepatitis C themselves. They use their personal history to build trust, where doctors and police cannot. They guide active users toward health departments for testing and supplies, acting as a non-threatening entry point for medical care. For someone who feels abandoned by society, seeing a peer who has survived this endemic can restore a sense of hope that their own recovery is possible. Solving the dual crisis of addiction and infectious disease requires a system of unwavering, non-compulsory support. Offering a clean needle or a free test without judgment is often the first step in restoring a person's sense of dignity, making them feel like a patient rather than a criminal. Breaking this cycle requires us to replace retribution with a model that protects human integrity. We have to treat the biology of addiction while respecting the agency of the individual. Addiction strips away a person's hope, but compassion can build it back. How can we shift our local communities away from a model of punishment and toward a model of harm reduction that protects the dignity of every human being?